Thank you so much, and thanks for having me. We're going to talk about how the face of Barrett's esophagus is changing. So we're going to step away from traditional histology-based risk stratification, instead use precision molecular risk stratification in the clinical management of Barrett's esophagus. We need to identify esophageal adenocarcinoma. It's incredibly deadly, 80% mortality rate. It has increased 800% since 1975, and Barrett's esophagus is the only known precursor to EAC, and Barrett's can be effectively treated with endoscopic eradication therapy or EET. However, surveillance per standard of care does not really identify Barrett's esophagus that are high risk for progression and would benefit from EET. Why do I say that? If you have a patient with high-grade dysplasia, there is a clear clinical action. You already be aggressive and send the patient for EET. However, how about those with non-dysplastic or low-grade dysplasia? Unfortunately, this is 95% of our Barrett's esophagus patients, and this presents that gray area where we don't really know, should we send a patient for EET? Should we just continue to monitor? Are we confident in just basing it on histology to risk stratify our patients? Telling you now that histology-based population rates of progression are very limited. We do 450,000 EGDs in a year, and 89% of those are diagnosed as non-dysplastic. However, we find that 50% of annual progressors are initially diagnosed as non-dysplastic, and more alarmingly, 25% of those have high-grade cancer, a high-grade dysplasia or cancer, even after just a year of an EGD. So what does that tell us? Did we miss this? How did we miss this? It tells us two things. Either the patient has prevalent disease and we missed it. We do our Seattle protocol perfectly, but even with our Seattle protocol, only 4 to 6% samples are taken from the esophageal tissue, and the pathologist can only read what's on the slide. Or does this patient have rapidly progressive disease that was not diagnosed as dysplastic? Again, we missed it. So how are we able to find these patients and not miss this progression? We used to think that traditional risk factors and histology are the ones that will guide us with risk of progression. Older, male, obese, long segment, these are the ones associated traditionally with who are at risk for progression. However, that seems to be not the case anymore. Patients 45 to 64 years old are experiencing increased prevalence of Barrett's. Women with Barrett's may not share the same clinical risk factors with males, and most importantly and interestingly, segment length does not predict persistence or progression for Barrett's esophagus. That caught me unaware initially too. In fact, ultra-short Barrett's, which is Barrett's less than 1 centimeter, has been shown to have similar persistence or progression as Barrett's that is 1 centimeter or greater. I thought that was really a change in your paradigm and how you risk stratify patients. So how are we going to risk stratify patients now if you can't use histology or the clinical risk factors? This is where TissueCypher comes in. TissueCypher is an AI-driven precision medicine testing for Barrett's esophagus. It's a prognostic assay that will help us identify who are more likely or less likely to develop progression of disease. What is it really? It objectively evaluates protein biomarkers and tissue structures to extract features. All these 9 protein biomarkers are statistically significantly identified to associate with progression, and they do the next step by quantifying these protein markers using digital microscopy with tissue structure. So it uses lab spatial omics to evaluate routine pinch biopsies. So what we do is we take our biopsies on EGDs. The slides show Barrett's esophagus. These slides get sent to their lab in Pittsburgh for immunofluorescence and slide staining. They obtain the 9 protein biomarkers. They do a whole side scanning and AI-driven image analysis, and it spits out a clinically actionable result. This result will guide us in clinical management, whether the patient is a low risk, intermediate, or high risk score. And this result is very personalized. It's actually the patient's molecular blueprint or molecular footprint of risk of progression. So it actually provides individualized 5-year risk of progression for high-grade dysplasia or EAC. It can be indicated for newly diagnosed non-dysplastic Barrett's, indeterminate, low-grade dysplasia, and patients already in surveillance. A high-risk score enables increased surveillance or early intervention. On the other hand, a low-risk score minimizes overtreatment and supports extension of surveillance intervals to guideline recommendations. We have GI Society support, and TissueCypher has been extensively studied. It has a robust body of clinical validation and utility evidence. It has 17 published clinical validation, utility, and experience studies. Medicare granted Advanced Diagnostic Laboratory Test, or ADLT status, for TissueCypher in 2022. What does that mean? It means that Medicare patients, TissueCypher is covered 100%. You don't need a prior authorization. You can run TissueCypher on these patients. And this is very interesting. TissueCypher can detect a molecular signature of progression that may precede morphologic changes. So this is a patient with a 2-centimeter Barrett's esophagus, 2-centimeter Barrett's. The top panel shows one segment. It was found to have low-grade dysplasia, however, with a high TissueCypher score of 8.9. The bottom panel shows another set of biopsies, same patient, same EGD, same day, just a different segment. It showed non-dysplastic Barrett's on histology. However, the TissueCypher still remains to be high. So like we talked about earlier, we cannot just rely on histology, because even with a non-dysplastic, it still shows that 8.7 risk. We do not want to miss this patient. What if we did not diagnose the low-grade dysplasia? Would have missed this patient because this patient actually had high-grade dysplasia on repeat EGD 56 days later. And TissueCypher touches on field effects. So even if you have different segments, the TissueCypher scores still are quite comparable. So it's very important if we have a high-risk score. It means that patients harboring prevalent disease are 46 times more likely to return a high-risk score, and high-risk patients without prevalent disease are 9.4 times more likely to progress within 1 to 5 years. These high-risk scores means that patient is either prevalent disease or rapidly progressive disease, and we don't want to miss these patients. Also, it identifies high-risk patients and traditionally low-risk patient populations that we have traditionally thought of as not progressive, the non-dysplastics, the females, and the short segments. TissueCypher can help guide clinical management. Instead of thinking more of that gray area population-based risk, we're now doing this personalized risk of progression. We're doing individualized risk-aligned treatment based on that patient's molecular signature or blueprint. How do we incorporate this in our practice? A low-risk patient, we can still consider surveillance 3 to 5 years and PPI per the guidelines. However, with a high-risk score or intermediate risk score, I would say all bets are off. We would take this very seriously. Because of risks of prevalent disease or rapidly progressive disease, I would send them for aggressive management for EET. So TissueCypher is committed to you and your patients. How do we go about it? You do your biopsies. Barrett's is diagnosed. All you have to do once you have the diagnosis of Barrett's esophagus, you or your staff can order it. And TissueCypher will discuss with your pathology lab on how to obtain the slides. The slides get sent off to the lab in Pittsburgh, and they will run their immunofluorescence and whole image scanning. What matters, it will show this result to you. It's easy to interpret. You have a risk class that is high, intermediate, or low. You have a risk score, and you have the 5-year probability of progression. So very, very important in helping guide management. You can also run TissueCypher every 3 years to really determine if the patient's progression has shifted. Yes, that's all I have for now. Thank you so much for your kind attention.